Hello, my lovely followers. I like you all. You're kind of weird sometimes, but together we're a strange little unit, and some of you have as much time for the BS I cover on my channel as I do, and I appreciate that. But this is how I received a very interesting email a few days ago, and let me tell you, it derailed my whole night. So I'm going to take you through my journey of that night so you can experience the roller coaster of thoughts and emotions that I went through. So let's begin. On a fateful Thursday evening, I received this email. For the sake of simplicity in this video, we're going to call the person who sent me this email Jordan. Hi there. My doctor sent me this literature after my labs showed high cholesterol. From this link, I clicked on Why We Don't Recommend Intentional Weight Loss. I could not believe this was sent to me by a medical professional, but I acknowledge that there could have been motivations behind this action that I am unaware of. Regardless, I'm wondering if you can create content around the validity or lack thereof of this information. So I'm curious. Let's look at the first link. So these first few pages talk about what cholesterol is and what causes high or low cholesterol, how it's diagnosed, nothing super interesting. Until we get to the fat phobia and body weight diagnosis. Despite what we know about extremely strong genetic factor of high cholesterol, there is a tendency to make the mistake of blaming cholesterol levels entirely on personal habits, especially eating and fitness habits. Furthermore, healthcare professionals often make the assumption about eating and fitness habits of fat patients and then make recommendations based on their assumption rather than accurate information, or simply recommend weight loss, which we know isn't ethical. Do we? Which isn't ethical, evidence-based intervention. You can read more about why we don't recommend weight loss here. We will get to that. So they're saying high cholesterol has extremely strong genetic factor, which, from what I can tell, isn't true. I looked up the genetic component behind high cholesterol, and there's something called familial hypercholesterolemia. So it's genetic high cholesterol, but it affects anywhere from 1 to 250 to 1 in 300 people. So very small percentage of people have this, whereas in reality, anywhere from 1 in 3 to 1 in 2 adults, so 33 to 50% or more percent of people in the United States are estimated to have elevated cholesterol levels or have had high cholesterol levels in their life. That is a lot higher than the 0.03% of people who genetically inherit high cholesterol. So this doesn't seem true at all. I'm sure there's some genetic factor to high cholesterol for all people in some respect, but it definitely isn't the most important factor in determining how someone got high cholesterol. That is mostly eating and fitness habits. This goes on to say how to treat high cholesterol, and it says stress management, smoking less alcohol consumption, food choices. Food can be used to support lowering LDL and increasing HDL cholesterol, including things like your consumption of whole grains, omega-3 fatty acids, nuts, and vegetables. Though LDL cholesterol may lower in the short term with dietary changes, there is limited evidence that dietary changes actually decrease the risk of heart attack and stroke. It is important to keep in mind that since cholesterol levels are primarily determined by genetics, cholesterol levels may not change significantly in the long term, even with changes in nutrition and eating habits. Also of note, cholesterol levels often increase when individuals severely restrict food intake, which we see, for example, with people with anorexia nervosa. Please note that nutrition is a young and developing science, and we recommend working with a qualified HAES dietitian around this, especially to avoid potentially triggering food restriction discussions. First of all, do not see a HAES dietitian. What is the point of a dietitian if they're only going to tell you to eat whatever you want? That doesn't make any sense. And as for this statement that cholesterol levels increase when you severely restrict food, from what I can tell, that is actually true. But in this context, it seems more like a red herring to try to say that if you have low cholesterol, then there's a good chance you could be overly restricting, even though you can definitely get higher cholesterol from eating too much or eating the incorrect foods in improper amounts. And there actually is a lot of evidence that if you do change your dietary choices long term, it can lower cholesterol, just like you can manage type 2 diabetes with your diet. This goes on to talk about sleep, physical activity, and medications to manage cholesterol levels. So this entire paper was absolutely crazy, but If you noticed, who actually sponsored this Hays Health Sheet? The Association for Size, Diversity, and Health. If you haven't watched my video on Lindo Bacon, I would recommend going to watch that to find out how wild this group is. This is the group that said that expecting someone to respond to an email within 5 months is a tactic of white supremacy. So I trust nothing they created, and I'm not surprised they made this. So that was the first sheet. Then I clicked on this why we don't recommend intentional weight loss, and folks, it's about to get way weird. So this entire sheet is on why they don't recommend dieting. Diets don't work. We're defining dieting here as any attempt to manipulate body size through food or movement. This would include short-term diets, fad diets, Wait, does that say fat diets? Well, they messed that up. Fat diets, diets that eliminate foods, and diets that are referred to as lifestyle changes. So any of you that made lifestyle changes and lost weight, it wasn't the diet. The diet didn't work. We know it doesn't work. If the goal is to create weight loss through food or movement, then it counts as a diet. While most people are able to lose weight short term, almost everyone gains it back, with up to 2/3 of people gaining back more weight than they lost. So even if someone believes that being thinner would lead to health improvements, and that's a big if, recommending intentional weight loss attempts is the worst possible advice, since it has the opposite of the intended effect the majority of the time. It goes on to talk about weight cycling, the harm of weight stigma, dieting leads to eating disorders. It says, dieting is one of the most important predictors of developing eating disorders. In fact, prescribing diets often equates to prescribing disordered eating behaviors. Dieting can lead to severe restrictive eating and malnutrition, cycles of starvation and binge eating, as well as other eating disorder behaviors and their medical complications. Weight loss pills and surgeries carry risk, and health at every size is a research-based paradigm. The evidence that exists around weight and health shows that understanding that health is not an obligation, barometer of worthiness, or entirely within our control. Health at every size interventions are health promoting and carry much lower chance of negative side effects. All of this has nothing to do with the objective facts around weight and health. Even if you believe health isn't an immoral obligation, or it doesn't have anything to do with your worthiness, or you know that some of our health isn't within our control, that doesn't change the fact that size and health are related. So then we get these papers. For a thoroughly cited review of evidence, we recommend reading this paper, and this one as well. So let's go. And here we get Weight Science, Evaluating the Evidence for a Paradigm Shift, written by, of course, Lindo Bacon. I don't trust anything Lindo Bacon has written in the past 15 years, so I don't trust this paper. I scanned through the paper, and it's mostly just cherry-picked and very carefully worded statements to convince people that size and health are not related. Like this statement down here that says, assumption, adiposity poses significant morbidity risk. Evidence, while it is established that obesity is associated with increased risk for many diseases, causation is less well established. Which is technically true, but it's also a really stupid point to make. That's like noting that construction workers are more likely to break their backs than an office worker. You can technically say that construction jobs don't cause people to break their backs, but that there is an increased likelihood of breaking your back if you are a construction worker versus working in an office. You could make the point that having a construction job doesn't directly cause people to break their backs more than people that work in an office, but you have to acknowledge that there is an increased risk of breaking your back working in construction versus working in an office. That's all this statement is, just carefully worded nonsense. There's also this assumption that anyone who is determined can lose weight and keep it off through appropriate diet and exercise. And they use this citation that more than 20,000 women maintained a low-fat diet, reportedly reducing their calorie intake by an average of 360 calories a day and significantly increasing their physical activity. After almost 8 years on this diet, there was almost no change in weight from the starting point, a loss of 0.1 kilograms, and average waist circumference, which is a measure of abdominal fat, had increased by 0.3 centimeters. But I actually looked at the results of this paper, and it says that women in the intervention group lost weight in the first year on average 2.2 kilograms and maintained lower weight than the control group during an average of 7.5 years of follow-up. No tendency towards weight gain was observed in the intervention group overall or when stratified by age, ethnicity, and body mass index. Weight loss was greatest among women in either group who decreased their percent of energy from fat. A similar but lesser trend was observed with increases in vegetable and fruit servings, and a non-significant trend towards weight loss occurred with increasing intake in fiber. And the conclusion says a low-fat eating pattern does not result in weight gain in postmenopausal women. So I didn't read this entire paper, but whatever point Linda was trying to make by saying that the weight loss was only 0.9 kilograms, even though in the summary of this paper it said that the average weight loss at the end of 7 years was 1.9 kilograms, they must have gone deep into this paper to get these numbers to make their point, because this is not what the results of that paper said. And there are many other examples of this type of stuff in this paper, but we're going to move on to the other paper because it's a lot. So this one is called What's Wrong with the War on Obesity? A narrative review of weight-centered health paradigm and development of 3C framework to build critical competency for a paradigm shift. Could you have made that longer? Okay, so this paper talks about how weight-centered health, or basically people talking about weight in a healthcare setting, is wrong. And it goes way further to make some insane claims. So let's go read through it. The message from health authorities in many parts of the world today is that having a body weight that is classified as overweight or obese is unhealthy. This message manifests in public health and health promotion policies and programs focused on obesity prevention. There are 4 weight-related paradigms. In the first paradigm, the body mass index, BMI, categories of overweight and obesity are problematized, and BMI is said to be reduced through limiting caloric intake and increasing energy expenditure. The second paradigm approaches the medically problematic BMI categories of overweight and obesity through an ecological lens addressing the obesogenic environment. Both of these paradigms place weight in the center of discussions about health and can be referred to collectively as the WCHP. The third paradigm focuses on optimizing psychological health and physical health and the well-being of people of all shapes and sizes through intuitive eating and enjoyable leisure and physical activity. The fourth paradigm moves beyond the individual level to promote flourishing in mind and body for all people by acting on the broader socio-environmental factors that impact on health and social issues such as weight bias, stigma, bullying, and discrimination. The third and fourth paradigms can be referred to collectively as the weight-neutral or weight-inclusive approach to health. Authors within the academic literature refer to their scholarship as critical weight studies, critical obesity studies, or fat studies. This isn't an academic paper. People wrote this down. The variation in terms reflect the nuanced ideological positions. However, they share common ground in critiquing the claims made by proponents of weight-based healthcare services. Despite this growing body of critical scholarship, weight-centered health remains dominant in the field of medicine, public health, health promotion, and within the general community. One strategy for advancing alternative paradigms is to review the values, assumptions, and claims of the dominant paradigm. They go on to the results section of this paper that goes into the context, critiques, and consequences of weight-centered health. And they created this chart, which is a monstrosity. It is awful to look at, but it is also hilarious. So we're going to start here. So the promulgators of weight-centered health paradigm. The slimmers, or the entrepreneurial self. They display moral worth by attempting weight loss. Oh, wow. We're starting out strong. So attempting to lose weight by anyone is someone trying to display moral worth to other people. Not for themselves, no. You are just trying to show the world how moral you are by trying to lose weight. Okay. Manage stigma and negotiate size discrimination. I don't get what that means. Healthcare professionals, they are the enforcers and administrators. They enforce weight rules and solutions with patients and offer authoritative advice. Yeah, that's what healthcare professionals do. They're supposed to tell you about your health and give you advice. What do you want? 3, anti-obesity campaigners, the supporters. They educate the public and mobilize support for anti-obesity campaigns. Yeah, that sounds about right. The scientific community, the creator. They set benchmarks for obesity classification and conduct obesity research. Oh my God, they conduct research? Also, did they spell research wrong? Popular media, the amplifier, moralizer. They uncritically report scientific facts about obesity and perpetuate concept of ideal body for health and beauty. All right. The government, the legitimator. They establish anti-obesity task force. They commission obesity reports and develop anti-obesity public policies and programs. So this is the CDC. They just don't like the CDC mostly. This entire chart was written in an academic paper, but this is so conspiratorial. They're basically saying that all of these people who believe that weight and health are in some way related are part of this grand conspiracy. But this is in an academic paper and not on a sketchy Reddit forum. And the last one is the weight loss industry, the opportunist supporter. They develop and market pharmaceutical products, promote and conduct bariatric surgery, and promote commercial weight loss products, services, and programs. This is the only one that kind of makes sense. All of the rest of these scream conspiracy. So if we follow the arrow upward, we get to the tenets of weight-centered health paradigm, still in the context portion of the chart. So the tenets of weight-centered health. 1, body weight is increasing rapidly around the world. That's true. 2, the body mass index and other measures of body weight or fatness are good indicators of current and future health status. Body weight, fatness, and the BMI definitely have their place in the context of predicting health status for a lot of people. So this one is still kind of accurate. 3, a BMI over 24.9 is a direct cause of disease and premature death. I would say this is half true because I don't think having a higher BMI is a direct cause of disease, but it is definitely heavily correlated with disease, especially if that BMI is above a 35. 4, increases or decreases in body weight are caused by a simple imbalance between an individual's energy intake and energy expenditure. Yes. 5, body weight is at least partially tional and within the control of the individual. Yes, that's true. 6, methods for successful and sustained weight loss for individuals are well known to science. Also true. Just because people typically don't stick to diets, that doesn't mean that we don't have scientific proof that long-term weight loss is possible. 7, changes in environment in the past few decades have created an obesogenic environment. Yes, absolutely true. 8, creating a less obesogenic environment will reduce the prevalence of obesity. Yeah, I think that's probably true. 9, focusing on body weight for all people and losing weight for overweight and obese people will result in achieving better health and reduce the personal, social, and economic costs associated with the higher than average body weight. Yes, true. So these are all tenets that they disagree with, even though I would say I agree with 8.5 of these. Number 3, I'm on board about 50%. So then we get to the critiques of the weight-centered health paradigm. And it's long. And we start with the ideological, subsection philosophical, biomedical and behavioral health paradigm, healthist, neoliberal, moral panic, objectivist, reductionist, fear-based, gender, class, and race discourses. What did I just read? What are they saying that weight-centered health paradigms are all of these things and all of these things are bad? But like, why is biomedical and behavioral health bad? And we're talking about health in this context, so why is healthist bad? And why moral panic about what? And objectivist? Isn't science supposed to be objective? Next we get to the ethical section. Maleficence, patriarchal, individual blame, disempowerment, prescribing ineffective treatment, surveillance and regulation of bodies and behaviors, and undeclared conflicts of interest. I don't know if this section makes more or less sense than the philosophical one. Patriarchal, prescribing ineffective treatment. Weight loss is effective even if people don't stick to the habits needed to lose weight. A doctor can prescribe anything to a patient, and if they don't actually take the advice, that's not the medical professional's fault. And maleficence, are they saying that the weight-centered health paradigm is currently malicious? And what is disempowering? Next one. The last section is human rights denials. There's only 3. Right to health, right to education, and the right to freedom from discrimination. How is our current healthcare system denying people a right to education or their right to health? I don't know. So next we have the empirical section of this critique. The first subsection is inaccurate representations in trends in body weight, determinants of body weight, and associations between weight and health outcomes. So I think what this is saying is that the current information we have about the association between weight and health is inaccurately represented in terms of the trends in body weight and the association between weight and health, which is not true. Next, ineffective for managing body weight and counterproductive. I don't know what that means. Last section, iatrogenic. I'm not going to look up what that means. Subsection, physiological harms. So these are the harms associated with the evidence we have when it comes to weight-centered health. Dissatisfaction, distraction, discomfort and distress, dutiful thinking, distrust of body, disembodiment or disassociation from one's body, depression. What are you being distracted from? What is dutiful thinking? And disembodiment or disassociation from one's body, the only thing I can think of with this section is body dysmorphia, but that isn't focused on one specific group of people, and that can happen to anyone at any size. Okay, next section. Behavioral harms. Delayed living, delayed healthcare, dieting, disordered eating and exercising. So dieting isn't automatically a harmful behavior, and delayed living, you don't have to delay living to lose weight, gain weight, love yourself, whatever. Next section, physical harms. Diminished healthcare, decreased nutrient absorption, decreased satiety, destabilized body weight, disease risk factors, death. Why not just go to the most extreme thing? Just say death. Why not? I would like an explanation for all of these, especially the decreased nutrient absorption and death, and the disease risk factors. I want information about how weight-centered health causes these physical harms to people. The last section, social harms. Dehumanization, discrimination, stigma, prejudice, and other forms of oppression. Let's get to the last section, the technical section. So we have limited strategy portfolio, expert-driven, and evaluation focus on behaviors and body weight, not health outcomes. Wait, okay, are they saying that it's wrong that it's expert-driven? Or are they saying it should be more expert-driven? What does this mean? Also, I have no clue what limited strategy portfolio means. And evaluation focus on behaviors and body weight, not health outcomes. But didn't they say they wanted more focus on behaviors? Why should you not focus on behaviors? Evaluation focus on behaviors and then body weight. So are they saying that we shouldn't focus on behaviors? God, who wrote this? Okay. Last section, we get to the consequences of the weight-centered health paradigm. And thankfully, I only have 3 things to read here. We get enhanced adipophobic ogenic environment. basically a fear of adipose. So basically an environment where people fear fatness or being fat. And that leads to reduced health and well-being and reduced quality of life. Okay. So people thinking that being fat is bad reduces people's quality of life and their health, even though being overweight, and specifically obese or morbidly obese, can definitely reduce your quality of life on its own, and that is something you should fear. You should fear being at a size where your quality of life is reduced. So that was that chart, and I have read my fair share of papers in my life, and this is hands down the worst chart I've ever seen. Not just in its content, but the actual structure of this chart or graphic or whatever you want to call it is awful. But this paper goes on to explain some of the things in this chart, and they do it so poorly. Let's go through a few of them. So in the inaccurate section, we get the trends in body weight, and it says, changes in prevalence of people classified as overweight and obese according to the World Health Organization in the BMI categories have been used to establish evidence for a need of weight-related public health initiatives. The prevalence of people with a BMI classified as overweight or obese is reported to have increased rapidly throughout the world, and that everyone everywhere is at risk of becoming overweight or obese. The use of such terms as global, epidemic, pandemic, and globesity have contributed to the notion that body weight is increasing exponentially and that these changes are sweeping through the populations of developed and developing countries alike. These statements are based on statistical increases in the proportion of people in the overweight and obese BMI categories over a 30-year period. The relativistic terms doubled and tripled serve to effectively dramatize these trends, despite the fact that the majority of these people are only 3 to 5 kilograms heavier than they were a generation ago. First of all, I would like to point out that most of the citations in this section and in this entire paper are really old. This paper was published in 2018, and almost all of the citations in this paper are from 2011 or sooner, and most of them are from the early to mid 2000s. And for a field like obesity that has changed a lot in the past decade and is extremely well researched, using a bunch of citations from 2001 and 2003 and even 2006 is not good. These citations are very old considering that this paper was published in 2018. Because this statement here that people are only 3 to 5 kilograms heavier than they were a generation ago, which first of all is a lot. 3 to 5 kilograms is about 6 to 10 pounds. 6 to 10 pounds on average per person in one generation is a lot. For a lot of people, especially women who tend to be smaller, 3 to 5 kilograms could be anywhere from 3 to 7% of their body weight. A 3 to 7% increase is not small. And not only that, this citation was from 2006. People have gotten a lot bigger between 2006 and 2018. So why is she citing this from 2006? And the next line is even worse. It says, furthermore, these terms give the impression that weight gain has occurred universally across the weight spectrum. However, for people at the thinner end of the spectrum, there has been no average increase in body weight since the early 90s, while for people in the middle spectrum, average weight has increased by 2 to 3 kilograms. This citation is from 2002. And if you actually read the paper, it makes it significantly worse. Because this paper is called The Prevalence and Trends in Overweight Among U.S. Children and Adolescents, 1999 to 2000. The results of this study say that the prevalence of overweight children is anywhere from 10 to 15% in the year 1999 to 2000. Again, this study that we're looking at was published in 2018. So she made this statement that the average weight has only increased by 2 to 3 kilograms, but they are using data that is 18 years old to make this claim. And this goes to show how heavily cherry-picked so many of the studies in this paper were. Because the authors clearly couldn't find more recent data to back up everything they said in this paper, so they tried to use very old data to make the point that the information we have about obesity and the trends in body weight are wrong, even though the trends they're looking at are wildly out of date. Later in this section, they do the same thing by saying, a data pooling study by Olds et al. Examined data for more than 500,000 children aged 2 to 19 from 9 countries between 1995 and 2008 and found that there were no overall changes in the prevalence of overweight and obesity in that time. But that is a horrible representation of what this paper actually says, because the conclusion of this study says, while the prevalence of overweight and obesity appears to be stabilizing at different levels in different countries, it remains high and a significant public health issue. So this paper knows that obesity is a problem, and they looked at obesity rates in 9 countries from Australia to England to Switzerland to the United States, and they averaged it amongst all those countries. So the fact that some countries may be stabilizing in their obesity rates and some even might be going down, that doesn't change the fact that in some places it's going up and is still a problem. And I guarantee the places that the obesity rate was going down was not in the United States. So this is another heavily cherry-picked study, but they use this study to say that the language used to describe trends in body weight is not reflective of actual changes in body weight over time, resulting in the suggestion that we are suffering from an epidemic of alarmist language. So they're saying that all of the alarmism about obesity is overblown because some countries have leveled out in their childhood obesity rates? That doesn't make sense. That's like saying that people are too worried about the heroin problem in the United States because the rates of death have leveled out. So why are we still talking about it? The number of deaths aren't increasing, so what's the problem? And in the next section, we have the determinants of body weight, which they're also saying that our ideas around what causes people to gain or lose weight is inaccurate. They have this section that says, in recent years, some of the anti-obesity focus in public health circles has shifted from individual responsibility to the role of the so-called obesogenic environment in enabling weight gain. A systemic review of 28 studies showed there was no association between obesogenic dietary behaviors and the food environment. However, living in a disadvantaged socioeconomic environment was consistently associated with so-called poor dietary behaviors. They took a single sentence out of this paper to support their point, but they took it far out of context. The summary of this paper says, weight status was consistently associated with the food environment. Greater accessibility to supermarkets or less access to takeaway outlets were associated with lower BMI or prevalence of overweight and obesity. However, obesogenic dietary behaviors did not mirror these associations. Mixed associations were found between the environment and obesogenic dietary behaviors. Living in a socioeconomically deprived area was the only environmental factor consistently associated with the number of obesogenic dietary behaviors. Associations between the environment and weight status are more consistent than that seen between the environment and dietary behaviors. The environment may play an important role in the development of overweight and obesity. However, the dietary mechanisms that contribute to this remain unclear, and the physical activity environment may also play an important role in weight gain, overweight, and obesity. But the only thing the authors took from that summary was that there was no association between obesogenic dietary behaviors and the food environment. So they took that one line and used it, even though there was a lot more complexity and nuance, even in the summary of that paper, than they let on here. I'm baffled that this paper was published. The sheer level of academic dishonesty and cherry picking that was done, and the fact that a board of people read over this paper and didn't take issue with the very old citations that are everywhere in this paper? I don't get it. So everything about that paper was baffling. But I went back to this original Why We Don't Recommend Weight Loss page, and I found this check out our resources link. So in this link, they have other useful resources, a self-advocacy card, and on this list is a spreadsheet for weight-neutral providers. So here is a list of all of the weight-neutral providers that I think people can submit and then have them put on this spreadsheet. And this got me thinking, if Jordan, the person who originally sent me this email, if their provider that sent them this link was on this spreadsheet. So I emailed them back and asked, And the response was very interesting. They said, "No, I go to this LGBT health clinic and my provider is not on the list. However, I'm happy you inquired because I was debating adding this information in the original email. I use this practice because I'm trans and I have been denied services and discriminated against elsewhere. With LGBT individuals already being a vulnerable group who distrust the medical system due to anecdotal experiences, are they not more susceptible to misinformation, or likely to trust haze when presented by a medical professional they trust to treat them fairly?" They have a point. Through everything I have seen, there does seem to be a common through line of fat activists not only aligning themselves with the LGBTQ community, but also a disproportionate amount of them are part of that community. And I don't think that is by accident. And I do think those communities are more susceptible to falling prey to haze and the misinformation in it when it's presented by a medical professional that they do trust. And I think this phenomenon is even more worrying considering a lot of LGBTQ clinics tend to be some of the most affordable healthcare, specifically in the United States, for a lot of people. So a lot of vulnerable people who may not be able to afford to go somewhere else or are worried about being discriminated against in other places will end up in clinics like this one that are promoting haze and spreading misinformation. And Jordan also sent me another email after this, and true to the word of the original document we looked at on cholesterol, Jordan was offered a haze dietitian through this clinic. This dietitian promotes intuitive eating and says this anti-diet approach includes a set of principles to help folks heal from dieting. And this is the dietitian being recommended to someone that was just diagnosed with high cholesterol. This is gross. The fact that this clinic is prescribing someone with high cholesterol to a haze dietitian that will probably tell them to do nothing and say that what they're doing is already enough and to simply be happier about their condition because their cholesterol issue is out of their control is gross. And I'm glad this person knew better than to go along with this, but it's appalling that a medical professional was sending around information like this. But this single link did occupy me for an entire night due to pure bewilderment when it came to these studies. And now, at least all of you got to share in my confusion, shock, and amusement. So I hope you enjoyed the video. I'm interested in seeing your thoughts in the comments, and I will see you in my next video.